Hey, what's going on, guys? Brandon here. Today, we're going to be looking at Health Assessment Textbook, Chapter 19, the Thorax and Lungs. This chapter, I don't know if I put in more effort into this chapter. It's long. It's very long. But we're going to get right into it, and then we're going to read the little key points. This should be a long one, but yep. So, looking at the position and surface landmarks, we got the anterior thoracic landmark, start the suprasternal notch, which is a U-shaped depression just above the sternum between the clavicles. And you got the sternum, which is the breastbone. You got three parts: the manubrium, the body, and the xiphoid process, followed by sternal angle, which is the articulation of the manubrium and body of the sternum. It's called angle Louis. Posterior thoracic landmarks, you got the vertebra prominence, spinous process, inferior border, scapula, and 12th rib. These are reference lines. So on the front, like the anterior portion of the body, the mid-sternal goes down the middle, mid-clavicular goes down the middle of the clavicles. It could also be on this side, and anterior axillary lines right here. These are on the posterior part, the vertebral and scapular. And on the sides, posterior axillary line, mid-axillary line, and anterior axillary line. Back, make sure you remember that. Alrighty, let's look at the thoracic cavity. It's basically a midsection of the thoracic cavity containing the esophagus, trachea, heart, and great vessels. Too bad. And looking at the lobes of the lung, right lung is shorter. Why? Because of the overlying liver, and left lung is narrower. Why? Because of the heart. You got anterior lobes of the lung. You got the oblique fissure, which crosses the 5th rib in the mid-axillary line and terminates at the 6th rib. It says 7th, but it's the 6th rib in the mid-clavicular line. And the horizontal fissure basically divides the right upper and middle lobes. Too bad. Let's look at lateral lobes of the lung. They're confusion points. The left lung does not have a middle lobe. The anterior chest contains mostly upper and middle lobes, very little lower lobe, and the posterior chest contains all lower lobe. Pleurae, basically serous membrane that forms the envelope between the lungs and the chest wall. Too bad, pretty easy. And visceral pleurae, it's one that surrounds the lungs. Think about like a visor. Protopleurae, it lines the chest wall and diaphragm, and you got the costodiaphragmatic recess. When the pleurae is 3 centimeters below the level of the lungs. And you got trachea and bronchial trees. You got dead space. It's basically air is in here, but it doesn't do any gaseous exchange. And what makes up the dead space is a bronchial and trachea. Easy. And you got essentially like a respiratory functional unit. Not too bad. You got 4 functions of the respiratory system: maintain homeostasis, heat transfer, bring in O2, and get rid of CO2. Pretty freaking easy. Hypoventilation, that's also pretty easy. So slow, shallow breathing, and that allows CO2 to build up. And then you got hyperventilation. It's fast, rapid breathing. Rapid, deep breathing. It causes CO2 to be blown off. Then you have a controlled respiration, like a major feedback loop. The humoral regulations, like changing CO2 and O2 levels. Then you have the normal stimulus to breathe, which is basically getting rid of O2. And you got changing chest size. How does the mechanical expansion and contraction of chest cavity alter the size of the thoracic container? 2 ways. The vertical diameter shortens and lengthens, which is caused by the diaphragm. And the AP anterior posterior diameter increases and decreases, caused by the ribs. So developmental confidence, emphasis in children, surfactant. This is needed for inflation of the air sacs, to keep the air sacs inflated, and usually present by 32 weeks. So some of the risk factors that can occur if mother smokes during pregnancy: you're going to have a low birth weight, small head, and sudden infant death syndrome, which is known as SIDS. So let's talk about the aging adult. What happens to the lungs as we age? Well, you got decreased vital capacity. It's like the maximum amount of air a person can expel from lungs after first filling lungs to maximum. So it's like you breathe all the way in until like you really can't breathe anymore, and then you breathe all the way out, and that's basically what it is. You got increased residual volume, amount of air remaining in lungs after expiration. So let's look at culture and genetics. The main things that were kind of cool were lung cancer, tuberculosis, and asthma. Moving on to subjective data. This is important. Coughing at certain times of the day, if it continues throughout the day, it's like acute infection. Acute illness is like a respiratory infection. If it's like afternoon or evening, could be caused by irritants at work. If it's at night, it could be like postnasal drift or sinusitis. And if it's in the early morning, it could be like smoking. Really. There's also sputum color production characteristics. If it's white or clear, it'd be like a cold, bronchitis, or viral infection. If it's yellow or green, a bacterial infection. Rust color could be like a TB, pneumococcal pneumonia. And if it's pink and frothy, it'd be pulmonary edema. Some conditions have a characteristic cough, like mycoplasma pneumonia as a hacking cough. Early heart failure that has a dry cough. Croup has a barking cough, and cold bronchitis and pneumonia have a congested cough. Mycoplasma pneumonia. Okay. Shortness of breath. We're looking at orthopnea. Basically, it's like difficulty breathing and lying down, and you classify it based on the number of pillows they need. You got proximal nocturnal dyspnea, waking up with shortness of breath in the middle of the night. You got the smoking history, mainly the 5 A's. You're going to ask, advise, assess, assist, and arrange. Ask, advise, assist, and arrange. Then I was reading about like, infants and children, like the pros of only breastfeeding for more than 6 months. Apparently, it protects against ear, throat, and sinus infections. And it's classed up to 6 years of age. Pretty freaking cool. So I also get like inspecting the posterior chest. The main thing was dealing with thoracic case AP diameter. It's usually less than the transverse, and the ratio is 0.7 to 0.75. Palpating the posterior chest, you use symmetric expansion. You put your hands here, and you have them breathe in, and it should move out the same width and length. Yeah, tactile fremitus. Fremitus is a palpable vibration. There are factors that affect the tactile fremitus. So basically, you hear them closer to the sternum. So the farther away you get to the sternum, like going down the body, the weaker the vibration will be. Also, if you have a lot of muscle or you're fat, a lot of fat, that'll make them weaker. So like less scanner fat you have, feel more. And if you speak in like a loud, like low pitch, that also increases it. You got decreased fremitus. It occurs with obstructive bronchus, pleural effusion, or thickening. So back barriers decrease fremitus. And then can increase fremitus. It's like compression or consolidation of lung tissue, like pneumonia. You also have bronchophlebitis and pleural friction fremitus, which we'll go over later. And when we palpate the entire chest wall, we can look for certain anomalies, such as like crepitus, which is a coarse, crackling sensation palpable over the skin surface. Not too bad. Then you have lung feels like resonance. It's a low pitch, clear, hollow sound that predominates in healthy lung tissue in adults. Then you have hyperresonance. It's a lower pitched booming sound found when too much air is present. And you also have a dull note, which is abnormal density in lungs as in pneumonia. Then we go to osculating the posterior chest. Some extraneous noise that may be confused with lung pathology. So like the examiner's breathing on stethoscope tubing, the patient shivering, patient having a hairy chest, and movement. Looking at normal breath sounds, there's 3 bronchial, like the tracheobronchial, vesicular, and vesicular. Bronchial, the pitch is going to be a high. Amplitude is loud. Duration is longer, and expiration when you breathe out, the inspiration breathing in. Quality is harsh, hollow, and tubular, and this usually occurs in the trachea and larynx. Bronchovesicular, the pitch, moderate. Amplitude, moderate. Its duration is the same length in inspiration and expiration. Quality, mixed. And then vesicular, the pitch is low. Amplitude Soft. Duration is longer in inspiration. Quality is like rustling, like the wind in the trees, and it's located in the peripheral lung fields. Let's talk about what causes decreased or absent breath sounds. Bronchial tree obstruction, emphysema, and this obstruction is really cool. And then we got adventitious sounds, like abnormal sounds that are heard in the lungs. You got crackles or rails. Crackles, discontinuous popping sound heard over respiration. And a wheeze, a continuous sound over expiration. You got atelectatic crackles. They're non-pathologic and they're short popping for few breaths. Looking at inspecting the interior chest, you want to look at the shape and configuration of the chest wall. Ribs should be sloping downward with symmetric interspaces. Costal angle should be 90 degrees. Facial expression should be relaxed and benign. No conscious effort should be needed for breathing. Level of consciousness, they should be alert and cooperative. Color and condition, their nails and skin color should be fine. And assess the quantity of respiration should be like automatic, effortless breathing. You go to palpating the interior chest, do the symmetric chest expansion, just like posterior. When we palpate posterior chest, do it in front and just feel it. And then we assess tactile vocal formitus, saying 99, pretty easy. Then we look at osculating the interior chest, look at forced expiratory time. How long does it take to empty lungs that are fully filled? Then you got spirometer, looks at healthy tissue, stuff like that. Then we go into developmental confidence in infants and children, the APGAR scoring. Good score, 7 to 10, anywhere between that. Zoom in on this if we can. APGAR scoring looks at heart rate, respiratory rate, muscle tone, reflex irritability, and color. Heart rate's over 100, it's 2. If it's under 100, it's slow. And if it's absent, obviously 0. Respiratory effort, if it's good, you got sustained cry and regular respirations, 2. If it's slow, irregular, or shallow, so 1. And if there's an absent respiratory effort, it's 0. Muscle tone, active motion and spontaneous flexions, 2. Some flexion of extremities, but some resistance to extension, so 1. And if it's limp and flaccid, it's 0. Reflex irritability, it's like a sneeze, cough, or cries, 2. 1 is a grimace or a frown, and 0 is no response. Then color, completely pink, it's a 2. If it's the body's pink and extremities are pale, it's a 1. And if it's cyanotic or pale over, it's a 0. Now looking at the aging adult kyphosis, that's basically humpback spine, basically outward curvature, thoracic spine. You see a picture of that in a second. Now let's look at some normal findings. This one is not abnormal. This looks normal. The normal adult's picture is a normal adult. What are the characteristics of what a normal adult will look like, basically, in relation to the thorax? Elliptical shaped thorax, and the AP to transverse diameter is 1.2 or 0.7. Alright, now looking at this one, what do you think this is? A barrel chest. What do you think the characteristics of a barrel chest are? Equal AP to transverse diameter, and ribs are horizontal. Alright, what do you think this is? This is pectus excavatus. What do you think the characteristics of pectus excavatum are? Whenever you say this, just think of a sunken sternum. Alright, move on to this one. What do you think this is? Pectus carinatum. I think characteristics of that is, yeah, protruding sternum. What is this? Pretty easy. Scoliosis. We think characteristics S-shaped vertebrae. And this. We just had it up here. It's Oh. Kyphosis. What do you think? Here this is humpback back. Humpback spine. Look at some respiratory patterns like boom, 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 but boom. What is that? It's a sigh. What do you think characteristics of sigh are? Well, it punctuates normal breathing and are purposeful to expand alveoli. Now, what do you think this is? It's like a bunch of these kind of same depth, but the rate is hella fast. He said tachycardia. Tachypnea, I'm sorry, you got it right. It's rapid shallow breathing, 24 plus rate. What about this one? The rate and the rhythm is high. What do you think? Hyperventilation? And what do you think characteristics of hyperventilation are? An increased rate and depth. What about this one? Look at it. What do you think it is? Bradypnea? I would say so. I think characteristics of bradypnea are slow breathing, decreased but regular pulse. What is this? Hypoventilation. Characteristics: irregular shallow pattern caused by an overdose of narcotics. Now, what do you think this is? The Cheyne-Stokes respiration. What do you think characteristics of the Cheyne-Stokes respiration are? Respirations gradually wax and wane in a regular pattern. I'm going to say this is diet respiration. With Cheyne-Stokes, it's a regular pattern, but diet respiration, this one's like that. It's regular pattern. You don't know when it'll happen. And this one. What do you think this is? Chronic obstructive breathing. What do you think characteristics are? Normal expiration, prolonged expiration. Bingo. Normal inspiration, prolonged expiration. Look at some abnormal tactile fremitus. I think this is. I think that is. He said increased tactile fremitus. You'd be correct. What's the characteristics of increased tactile fremitus? Basically, it's basically increased the density of lung tissue. What about this? Decreased tactile fremitus. And characteristics? Basically, any obstruction, anything that obstructs transmission of vibrations. So any barrier that gets in the way of sound. And how about this one? So the bronchophremetus. Basically caused by like congested mucus, like mucus and stuff like that. Thick secretion is the larger bronchi. And this one. Pleural friction fremitus. Inflammation causes that one. Alright, let's look at some adventitious lung sounds. So some discontinuous sounds, discrete cackling sounds. So look at this one. How can I grab a book so I can describe this to you? Okay. Let's see. So you have some noise at the very, it's kind of at the very end of inspiration. What would you say to? Well, if you said crackles, fine crackles, you're correct. What are the characteristics of fine crackles? Discontinuous, high-pitched, short crackling, like so popping sounds heard during inspiration, and coughing does not clear these. So noises heard during inspiration, abnormal noise heard during inspiration, pop it. Easy. How about this one? You can kind of tell his noises kind of mainly through all inspiration and a little bit during expiration. What do you think is this? Coarse crackles. Characteristics, obviously, what we just said. Loud, low-pitched, bubbling, and gurgling sounds that start in early inspiration may be present in expiration. Alright, look at this one. I'm going to describe it to you. Just a little bit, just like the fine crackles, a little little abnormality sounds at the beginning, but slowly looks like it diminishes and it goes away. What do you think it is? Talatatic crackles. What are the characteristics of talatatic crackles? They sound like fine crackles, but do not last and are not pathologic. Disappear after the first few breaths. Alright, and this one. What is this one? Kinda sound on inspiration and expiration. What do you think this is? Pleural friction rub. What are the characteristics of that? It's a very superficial sound that is coarse and low pitched. It's inspiratory and expiratory. So what are continuous sounds? Basically connected musical sounds, really. See, this one's a bunch of E's. What do you think this is? Maybe a high-pitched wheeze? What do you think the characteristics of a high-pitched wheeze are? Maybe a high-pitched musical squeaking sound that sound polyphonic. Look at this one. Maybe it's a little bit just to the end of inspiration, but a lot at expiration. What do you think this is? A low-pitched wheeze, correct. And what are the characteristics of low-pitched wheezes? Low-pitched, obviously, monophonic, one musical note, moaning sounds, really. And this one's stridor, obviously. What is it, stridor? High-pitched, monophonic, speed. Alright, let's talk about some voice sounds. Bronchophony, the technique. Well, we know about it. The technique, you're going to listen to the back, and you're going to have the patient say 99. So you ask the person to repeat 99 while you listen with a stethoscope over the chest wall, especially spec pathology. Normal, you should not be able to distinguish exactly what's being said. And abnormal this is not good. If you hear what they're saying, it's abnormal. Egophony technique, you're going to listen just like you do, but you're going to have them say E sound. Normal, you want to be able to hear it, but if you hear A, it's bad. And whispered pectorially, do the same thing, but you have the person whisper 1, 2, 3, 1, 2, 3 over and over again. And normal, you do not really want to understand it, and it's abnormal if you can. Let's look at some common respiratory conditions. This is actually normal. This is a normal lung. Upon inspection of the person's normal lung, you'll see the anterior posterior diameter is less than the transverse. Person will be relaxed posture, normal musculature. The rate would be 10 to 18 breaths per minute, regular, no cyanosis or pallor. When we palpate them, what do you think that's going to be? Symmetric chest expansion, tactile firmness is present and equal bilaterally, diminishing toward peripherally, no lumps, mass or tinnitus. What would it be if we percussed the normal lung? It would be resonant sounds. How about osculating? Vesicular over peripheral fields, bronchovesicular, parasternally, and between scapulae, infants and young children, bronchovesicular throughout. And any adventitious sounds? No. Alright, let's go on this one. What is that? What is going on here? What is that? Collapse. Atelectasis. This is collapse. What is the condition of this atelectasis? It would be collapsed, shrunken alveoli or the entire lung because of extruction. Could be caused by compression or the lack of surfaction. What about if we expected someone with atelectasis? What would that be like? They would have a cough, a lag on expansion on affected side. You have increased respiratory rate and pulse, and possible cyanosis. Cool. What about if we palpated someone with atelectasis? Chest expansion decreased on affected side. Tactile fermentus decreased or absent over area. It's large collapse tracheal shift toward affected side. What about if we percuss someone with atelectasis? Dull over the area. What about if we osculated them? Breath sounds decreased, vesicular or absent over area. Voice sounds variable, usually decreased or absent over affected area. Any adventitious sounds. No, if bronchus is obstructed. However, if bronchus is pallid, there will be some occasional crackles. Fine. Alright, what is this? Said lobar pneumonia would be correct. What is the condition of lobar pneumonia? I'm just going to say it. White blood cells, red blood cells get into the alveoli. And that's what's up. What's the history of someone with lobar pneumonia? Fever, cough with pleuritic chest pain, blood-tinged sputum, chill, shortness of breath, and fever. What about when we inspect them? Increased respiration is definitely higher than 24. Guarding and lag on expansion affected side. About palpating someone with lobar pneumonia. Pulse is definitely greater than 100 beats per minute. Chest expansion decreased on affected side. Tactile formitus is increased if bronchus is padded, decreased if bronchus is obstructed. What about percussion? It's dull over lobar pneumonia. And osculation? Tachycardia, loud bronchial breathing with patent bronchus. Voice sounds have increased clarity like bronchophony, agophony, whispered particularly present. All three of these. Wow, that's crazy. And adventitious sounds, crackles like fine and medium. What is this? Say acute bronchitis. Good job. What's the condition of acute bronchitis? Basically, it's an acute infection of the trachea and larger bronchi characterized by a cough lasting up to 3 weeks. Alright. What would you find if you suspected someone with acute bronchitis? Basically, cough would be productive or non-productive. You'd have a sore throat, low-grade fever, postnasal drip, fatigue, and substernal aching. What about if you palpated someone with acute bronchitis? What do you expect? Well, there would be no pain and no increased formitus. What about if you percussed them? Prominent sound would be resonance. And what if you osculated them? Maybe clear and equal bilaterally, no agophony. And any adventitious sounds? Nope. Cool. Alright, what do you think this is? You said chronic bronchitis, you would be correct. What is the condition of chronic bronchitis? Basically, proliferation of mucus glands in the passageways, resulting in excess mucus secretion. What you find when you inspect chronic bronchitis? Basically, you get a hacking, rasping cough productive of thick mucoid sputum and palpate. Tactile formitus would be normal. And what about percussion? Resonant sounds. And how about when we listen to it with our, I don't remember what the name are. Diaphragm bell. Normal vesicular, voice sound normal, and any adventitious sounds. Some crackles, may have wheezes. Alright, what is this? Said emphysema, you're correct. What's the condition of emphysema? Well, it's caused by destruction of pulmonary connective tissue, characterized by permanent enlargement of air sacs, distal to terminal bronchioles, and rupture of interalveolar walls. Alright, what about if we inspect someone with emphysema? What would we find? You'd have an increased anterior posterior diameter, barrel chest, accessory muscles used to aid respiration, tripod position, shortness of breath, especially on exertion, respiratory distress, and definitely tachypnea. What about if we palpated someone with emphysema? what will we find? Decreased tactile fremitus and chest expansion. What about if we percuss on with emphysema? Hyperresonant. And if we osculated them, decreased breath sounds, may have prolonged expiration, muffled heart sound resulting from overextension of lung. Sure. Any adventitious sounds? Usually none, maybe a wheeze. What is this? It said asthma, you're correct. What's the condition? Asthma? Allergic hypersensitivity to a variety of things like allergens, irritants, micro stress, exercise. If we inspected asthma, during like severe attack with increased respiratory rate, shortness of breath, audible wheeze, use of accessory neck muscle, cyanosis, apprehension, retracted intercostal spaces, expiration, labor, be prolonged. When chronic, may have barrel chest. What about with palpated asthma? Tactile fremitus would be decreased and you'd have tachycardia. And with percussed asthma, there would be resonant sound, maybe hyperresonant if chronic. And auscultation, diminished air movement, breath sound decreased with prolonged expiration, voice sound decreased. And any adventitious sounds, bilateral wheezing on expiration, sometimes too bad. What is this? It's a pleural effusion. Basically, you got fluid buildup. Collection of fluid in space. Yep. What's the inspection of it? What would that be? Increased respirations, dyspnea, may have dry cough, tachycardia, cyanosis, asymmetric expansion, abdominal distension. About with palpate, pleural effusion. Tactile fremitus would be decreased or absent, tracheal shifts away from affected side, chest expansion, decreased non-affected side. And percussion of pleural effusion, dull percussion over affected area because of the fluid. And auscultation, breath sounds decreased or absent, obviously. And any adventitious sounds, you got crackling or pleural rub. What's this? Heart failure. That's what that is, heart failure. It's a long chapter. We're already at what, 33 minutes-ish? Basically, condition is pump failure with increasing pressure, cardiac overload, which causes pulmonary congestion or an increased amount of blood present in pulmonary capillaries. What about when we expect heart failure? Got like increased respiratory rate, shortness of breath on exertion, orthopnea, paroxysmal nocturnal dyspnea, nocturia, ankle edema, pallor, and light-skinned people. About when we palpate heart failure, skin will be moist, clammy, but the tactile fremitus is normal. And when we percuss it, you got resonant. And osculate it, normal vesicular, heart gout sounds, include extra gout. Any adventitious sounds, yes, crackles at the lung bases. What is this? It's a pneumothorax. What's the condition of pneumothorax? Basically, it's free air in pleural space causes partial and complete lung collapse. It can be spontaneous, where air enters pleural space through rupture in lung wall. It can be traumatic, air enters through opening or injury in chest wall. Or tension, trapped air in pleural space increases compressing lung and shifting mediastinum to the affected side, unaffected side. About we expect pneumothorax, unequal chest expansion, if large, tachypnea, cyanosis, apprehension, bulging, and interspaces. What about when we palpate pneumothorax? Tactile fremitus is decreased or absent, tracheal shift opposite side, chest expansion decreased on affected side, tachycardia decreased BB. About when we percuss pneumothorax, hyperresonant. And when we osculate pneumothorax, breath sounds decreased or absent, voice sounds absent or decreased. And any adventitious sounds, nah. 4 more. Well, this one. I'll lie, 5 more. Yet. It's a pneumocystis jirovecii pneumonia. Condition. The virulent form of pneumonia is a protozoal infection associated with age. When we expect it, you got anxiety, shortness of breath, dyspnea on exertion, malaise are common, also tachypnea, fever, a dry, non-productive cough, intercostal retraction in children and cynos. And palpation. Decreased chest expansion, percussion, dull over areas of diffuse infiltrate. Auscultation, breath sound may be diminished. And fictitious sounds, crackles may be present but are often absent. What is this? It's TB, tuberculosis. It's a condition of tuberculosis. Inhalation of tuberculous bacilli and alveolar wall starts. You got acute inflammatory response that leads to scar tissue and then reactivation of previously healed lesion. Subjective tuberculosis, what would you find? It's initially asymptomatic, showing as positive skin test or on X-ray study. Rest of TV involves weight loss, anorexia, easy fatigability, low-grade afternoon fevers, night sweats, may have pleural effusion, recurrent lower respiratory infections. Inspection of tuberculosis. Cough, initially non-productive, later productive of purulent yellow-green sputum. Maybe blood tinge, dyspnea, orthopnea, fatigue, and weakness. And palpation. Skin moist at night from night sweats. Percussion. Resonant, initially dull over any effusion. And auscultation, normal or decreased vesicular breath sounds. Fictitious sounds, crackles. We get to pulmonary embolism. That's what this is. Condition. Undissolved materials originating in legs or pelvis detach and travel through the venous system, returning to blood to right heart and lodge to include pulmonary vessels. Subjective. Chest pain, worsen on deep inspiration, dyspnea. Inspection. Apprehensive, restlessness, anxiety, mental status changes, cyanosis, tachypnea, cough, hemoptysis, O2 status 80. We palpate it. Diaphoresis, hypertension, osculation, cardiac vicious sounds, usually crackles and weasels. Alright. Acute respiratory distress syndrome. This is what this is. What is it? Acute pulmonary insult, which damages alveolar capillary, leading to increased permeability of pulmonary capillaries and alveolar pulmonary edema. Acute respiratory distress. Okay. Subjective, acute onset of dyspnea and apprehensive. Inspection, restlessness, a bunch of shit. Palpation, hypertension, osculation, tachycardia, and vicious sounds, crackles, and raunchy. Last one. Lung cancer. Condition. This is the most fatal of malignancies, claiming as many lives per year as breast, colorectal, prostate cancers combined. Subjective. Fatigue, nausea, vomiting, inspection, weight loss, clubbing, hoarseness, anemia, escalation, wheezing, telekinesis. Okay, time to read this. Key points. Thoracic cage consists of the sternum, 12 pairs of ribs, 12 thoracic vertebrae, and the musculotendinous diaphragm, which forms the floor separating the thoracic cavity from the abdomen. On the anterior thorax, surface landmarks include the suprasternal notch, the sternum or breastbone, the sternal angle, which is continuous with the second rib, and the costal angle, where the right and left costal margins meet the xiphoid process. On the posterior thorax, surface landmarks include vertebral prominence, spinous process, the inferior border of the scapula, and the 12th rib. Reference lines of the chest are mid-sternal, mid-clavicular, vertebral and scapular. Axillary lines are the anterior, posterior, and mid-axillary. Mid-mediastinum contains the esophagus, trachea, heart, and great vessels. The right and left pleural cavities on either side of the mediastinum contain the lungs. Anteriorly, the apex or the highest of the lungs, lies 3 or 4 centimeters above the inner third of the clavicles. The base, or the lower border, above the inner third of the clavicles. The base rests on the diaphragm laterally. The lungs extend from the apex of the axilla to the 7th or 8th rib. Posteriorly, C7 marks the apex, and T10 usually corresponds to the base. On deep inspiration, the lower border drops to T12. Right lung shorter than the left lung and has 3 lobes. The left lung has 2. The pleura form an envelope between the lungs and the chest cavity. Pleural cavity is a potential space that contains lubricating fluid. Cavity normally has a vacuum or negative pressure that holds the lungs tightly against the chest. The lubricating fluid prevents friction as the lungs move during respiration. Trachea lies anterior to the esophagus. It bifurcates with the right bronchus being shorter, wider, and more vertical than the left. Bronchial tree protects the alveoli from small particulate matter by using mucus and cilia, which sweep particles upward for swallowing and expulsion. The respiratory system has 4 major functions. First, it supplies oxygen to the body for energy production. Secondly, it removes carbon dioxide as a waste product of energy reactions. Third, it maintains homeostasis or acid-base balance in arterial blood. And fourth, it maintains heat exchange. Thorax and lungs undergo developmental changes. The respiratory system develops in utero but does not function to birth. Continues to develop during childhood and reaches adult size by adolescence. During pregnancy, the growing uterus displaces the diaphragm. The fetus increases maternal oxygen demands, which are met by an increased tidal volume. In older adults, the costal cartilage becomes calcified, respiratory muscle strength declines, and lung elasticity declines, making the lung less distensible and lessening their tendency to collapse and recoil. Lung cancer is the second most diagnosed cancer in both men and women, but is the leading cause of cancer death in the United States. Smoking is the leading cause of lung cancer. Cultural differences related to lungs pertain to incidence of tuberculosis and asthma. Allergic asthma involves a complex interaction between genetic susceptibility and environmental factors. Long-term exposure to traffic-related pollution increases risk for allergic disease in children. Alright, to obtain subjective data, ask questions that investigate for cough, shortness of breath, and chest pain with breathing, history of respiratory infections, smoking, and environmental exposure, and participate in pneumonia and influenza immunization programs. To obtain objective data, inspect the posterior and anterior chest, noting the shape, configuration and symmetry of thoracic cage, the quality of respiration, skin color, and patient's position for breathing. Palpate the thorax and lungs, assessing the entire chest wall for chest expansion, firmness, and any lumps, masses, or tenderness. The continued examination, percuss over the lung fields, assess for resonance, which is a normal finding. Then auscultate the posterior and anterior chest to evaluate the presence and quality of breath sound. Normal breath sounds in an adult and older child are bronchial, bronchiovesicular, and vesicular. Adventitious sounds or normal sounds are crackles, rails, telectatic crackles, and wheezes. Indicated. Also measure forced expiratory time and assess arterial oxygen saturation with a pulse oximeter. Assess of the infant's chest and lungs includes inspection, palpation, osculation, but no percussion. That's probably important. In the pregnant woman, thoracic cage and costal angle are wider. Respirations are deeper with a 40% increase in tidal volume. 6-minute walk test is used to measure respiratory function in older adults. Older adults may exhibit a barrel chest, kyphosis, or outward curvature of the thoracic spine. As part of the assessment, include health promotion. For example, discuss exposure to secondhand smoke, which increases a patient's risk of adverse health effects. Alright, that was long. I'm done. Deuces.